This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
What I will try to do with you is to talk about the impact that differences in the ability of insulin to stimulate glucose uptake plays and how the body responds to that defect, the importance of these abnormalities in a series of very important diseases. A method that we have been using to actually quantify insulin action. So with this technique, we can determine how effective insulin is. And it's a very, very simple technique. It's called the insulin suppression test. And what we do is we will give intravenous infusions for 3 hours to the participants, and we infuse them, or we give them by vein, 3 components. A compound called somatostatin. And somatostatin is a compound which inhibits the ability of the pancreas to make insulin. So we are, in a sense, taking away the person's own insulin, and we are infusing at the same time, we are infusing insulin from a bottle. And by doing this, we can, after a couple hours, attain a steady state of insulin in the blood of everybody. So the last half hour, we measure every 10 minutes the insulin concentration. Now, since we've suppressed their own insulin and are giving them insulin that's the same to everybody, everybody reaches the exact same level of insulin. Now, what insulin is supposed to do is to put glucose into the appropriate tissues. At the same time, we're infusing them with glucose, sugar, glucose. And after a couple hours, we get a steady state plasma glucose concentration. Now, since everybody is getting the same amount of insulin and the same amount of glucose, if everybody's tissues were equally sensitive to insulin, they would have the exact same steady state plasma glucose concentration. To the degree to that level varies, we have a direct measure of how effective insulin is. The lower the value, the lower the blood sugar, the more effective insulin has been, and the higher the blood sugar, the less effective the insulin has been. So the higher the steady state plasma glucose, the more resistant. The lower the glucose, the more sensitive. We have recently published the results of 490 such measurements in a series of apparently healthy adult volunteers. So each of these blue bars represents the average steady state plasma glucose concentration of 49 people. And remember, the lower that value, the more insulin sensitive the patient, and the higher that value, the more insulin resistant the patient. Now, what you can obviously see is that there is an enormous variation from person to person. And in this group of apparently healthy individuals, there is approximately a 6 to 8-fold 600% to 800% variation in this healthy population. There is no other biological phenomenon that varies that much. So here we have the most simple biological action. Insulin disposing of the glucose coming into the body, and these people are all normal, and yet it varies that much. And what this means is that the body is very interested in preventing anything bad happening, so it maintains this blood sugar at a certain level by making enough insulin to overcome this resistance. Again, as you can see, besides this enormous variation, there is no sharp cutoff point. There is no obvious way to say which of these people are resistant to insulin and which are sensitive. Certainly, these are most sensitive, these are most resistant, but in between there is no sharp cutoff point. So, as we'll see, this provides a certain dilemma in terms of how to approach both the diagnosis and treatment of such individuals. Well, what is it that accounts for the variability that I just got through showing you? And there are two major points. What this graph shows, each of these blue points here is a person. So this is roughly 400 people. Down here is a value, or is a measurement called body mass index, or BMI. Well, BMI is an objective way to try to estimate how the degree of adiposity of a person. And it's a function of how tall you are and how much you weigh. Now, both in Europe and the United States, there's been a general agreement that if you have a body mass index, BMI, less than 25, you're normal weight. Between 25 and 30, you're overweight. And above 30, that's classified as being obese. So you can see this population of people in the Bay Area and Peninsula area, there was a range from less than 20 to almost as high as 40. Now, up here is the steady-state plasma glucose for each person. Remember, the lower the value, the more insulin sensitive, and the higher the value, the more resistant. Now, it's very obvious that by and large, as the BMI increases, you become more, the patients are more and more insulin resistant. And this line represents the relationship. But as you also can see, there are individuals with very heavy BMI, definitely obese, who are very insulin sensitive. And there are individuals who are not overweight, who are very insulin resistant. So all this slide says to you is that a major regulator of the degree of insulin resistance is how heavy you are. And this accounts for approximately 25% of the variability from person to person in the world, in the population at large. So how heavy is a major regulator of how insulin resistant you may be. The heavier, the more resistant. The next slide now evaluates the impact of how physically fit you are. The measurement down here, which is called VO2 max, is just a measure of how physically fit you are. And the higher that number, the more fit you are. In this case, we've measured insulin action by a different technique, very similar but somewhat different. So in this case, the higher the value, the more insulin sensitive, rather than the more insulin resistant. The blue dots are men, the yellow dots are women. And what you can see, again, very simply, is that by and large, the more fit you are, the more insulin sensitive you are. The less fit, the more resistant. This also accounts for about 25% of the variability from person to person. And this is very important because it means that roughly half of the variability from person to person can be modified by changes in physical fitness or changes in weight. And for example, we talk about cholesterol levels, that's mainly genetic. In this case, probably no more than half of the variation from person to person is genetic in nature. Why is that important? And I'm going to list, without showing the data, a whole series of abnormalities that are related to insulin resistance. First of all, if you're insulin resistant, you're going to try to secrete large amounts of insulin to prevent the advent of diabetes. So high levels of insulin are part of being insulin resistant. Although you may not get frank diabetes if you're insulin resistant, you frequently have some degree, modest degree, of what's called glucose intolerance. You have a series of abnormalities in lipid metabolism. You have tend to have a high triglyceride, a low level of what's called HDL cholesterol, or high density lipoprotein cholesterol. The higher that value, the more heart attack is likely. The lower that value, the more heart attack is likely. There is a change in the actual particles of the LDL. They become smaller, and that also increases risk of a coronary. And lastly, after you eat, there is an accumulation of triglyceride-rich particles. All of these things, acting together because they're all connected, greatly increase coronary heart disease risk. In addition, the lining of the blood vessels is called the endothelium. And there are a series of abnormalities in the endothelium, which I won't dwell on, but simply point out all of these, again, increase the risk of getting a heart attack. The chances of getting coagulation, of having a clot form in your blood, in your arteries, because of these two changes, is also increased in individuals who are insulin resistant. There are markers of inflammation in the blood vessel wall, which are also increased in insulin-resistant people, and again are a marker of greater risk for heart disease. In addition, there are changes in something called uric acid. It's been known for many years that patients with coronaries who've had a heart attack tend to have higher uric acid. And this is because of insulin resistance. The insulin acts in the kidney to prevent the removal of uric acid, so it builds up in the blood. The kidneys retain more sodium if you are insulin resistant. And there's an increase in the blood vessel control, in the nervous system control of your blood vessels, which again increases the risk of hypertension. Finally, the ovaries are stimulated by the excess of insulin to make more testosterone in women. So another change that takes place. So a whole series of abnormalities that will occur more likely in individuals who are insulin resistant. And these things are the basis of a series of very important diseases. So first of all, and we'll major discuss later on tonight, will be a major point of discussion, will be patients who are healthy volunteers who are insulin resistant and have high levels of insulin, and all the changes I've shown you a few moments ago are at greatly increased risk to get a heart attack. They are greatly increased risk to get type 2 diabetes. What type 2 diabetes is simply are individuals who are insulin resistant and have lost the ability to make enough insulin to overcome that resistance. So finally, the blood sugar goes up. Essential hypertension. Half the individuals with high blood pressure have it because they're insulin resistant. When I say half, approximately half of the patients with hypertension is part of this insulin resistant cluster. And it's those patients who have hypertension And the other manifestations of insulin resistance are the ones who get heart attacks. There is a syndrome called polycystic ovary syndrome. It's the most common endocrine abnormality in premenopausal women. And because of the excessive testosterone secretion from the ovary, due to the high levels of insulin, these women are unable to ovulate, will frequently appear more masculinized, and they are unable to bear children. And that's secondary to insulin resistance. There is a deposition of fat in the liver. Most of the time when people have had fatty liver disease, it's been assumed to be due to excessive drinking. This is non-alcoholic fatty liver disease, and that clearly is related to the excessive production of fat by the liver in insulin-resistant people. And more recently, there is evidence that certain forms of cancer, breast cancer, colon cancer, prostate cancer, are more likely to occur in insulin-resistant people. So this is a very serious abnormality, and as I said, it's present in a large number of the apparently healthy population in the world. Now I want to turn and focus a little bit on heart disease and explain to you why patients who are insulin resistant are more likely to have heart disease. So because of the insulin resistance, as I told you, if they can make a lot of insulin, they will not get diabetes. Again, type 2 diabetes is the failure to make lots of insulin. The combination of these changes will make the liver make more fat. Part of that fat stays in the liver, and that's why you have this non-alcoholic fatty liver disease. But the other part of the fat will come out in the blood and give you a high triglyceride concentration, and a high triglyceride concentration, which is a kind of fat in the blood, is a marker of risk of cardiovascular disease related to the 4 other changes I've shown you a few moments ago. So what is the evidence that individuals who have insulin resistance get heart disease? This is one study we actually did in Italy with some colleagues over there, and we've been following roughly 800 healthy volunteers in a factory in Italy. And at the beginning, they were put into groups of 4 quartiles based upon how high their insulin was. So this was the group with the lowest insulin, and this was the group with the highest insulin. And it's very obvious that the 25% of the individuals with the highest amount of insulin had an increase almost 20-fold in the risk of developing some abnormality of glucose tolerance over time. And the same thing is true of hypertension. So again, the same 4 groups: lowest insulin, highest insulin, most sensitive, most resistance. The upper 25% had a doubling of the development of essential hypertension over this period of time. And lastly, here's coronary heart disease. And again, the most insulin resistant 25% had at least almost a quadrupling risk of getting heart disease. So again, insulin resistance and the hyperinsulinemia that's part of the insulin resistance greatly increases the chance of getting 3 important diseases here: diabetes, high blood pressure, and a heart attack. It's a very serious problem. So in this case, you'd say, well, the upper 25% is the group that's most at risk, which is a lot of the population, 25% of apparently healthy population. Now, as I said before, it's the triglycerides which is the easiest marker to measure of insulin resistance. But as I said, once you have a high triglyceride, you're likely to have a low a low value of this protective particle, high density lipoprotein. So the lower that value, the more at risk for coronary heart disease. Again, as I said, the LDL particle gets smaller and denser and is more easily oxidized and also highly atherogenic. And there is this increase in the postprandial, post-eating, day-long values of triglyceride particles which are highly atherogenic and lead to coronary heart disease. The next 4 slides are really very important because, again, it emphasizes how central these problems are to your health. These were studies that were done by a young Danish investigator who actually spent a couple years at Stanford. And what he did was he took 4 situations known to increase coronary heart disease risk, so-called conventional risk factors. And here it was smoking. And they divided the population into 3 categories. The blue bars are individuals who have a very low triglyceride and a very high HDL cholesterol. These are the insulin-sensitive individuals. The green, that bar, are the individuals with the highest triglycerides and the lowest HDL cholesterol, therefore the insulin-resistant group. And then he asked the question, what proportion of these people developed a heart attack over time? Well, as you can see in people who didn't smoke, non-smokers, if you had insulin resistance and the lipid consequences, a high triglyceride and a low HDL, you had a dramatic, significant increase in your risk of heart disease. But more importantly, if you were a smoker and were lucky enough, for whatever reason, to be insulin sensitive, there was a very little of an increase in coronary heart disease risk. But if you were a smoker and also had insulin resistance, as you can see, you're the group most at risk for coronary heart disease. This is hypertension, the same story. If you had a normal blood pressure but still were insulin resistant, you had more than the doubling of your chances of getting a coronary over this period of study. So heart attack was increased in the absence of hypertension, in the presence of insulin resistance. If you had high blood pressure, but were the population that had high blood pressure but were insulin sensitive, there was no increased risk of coronary heart disease. Again, if you were the population that had high blood pressure and insulin resistance, again, by far the most deadly combination. This is physical activity. Very active people, very sedentary people. If you were highly active in this population in Denmark and you were insulin resistant, you still had a doubling of your heart attack risk. If you were very sedentary, typical couch potato, but were lucky enough to be insulin sensitive, you had no increased risk of coronary heart disease. Again, if you were both inactive and insulin resistant, you had the highest risk of coronary heart disease. Now here is a low-density lipoprotein cholesterol level. It's what we frequently think of as the major cause of heart attack risk. If you had a low, in quotation marks, LDL cholesterol, low cholesterol, and insulin resistant, you still were in real trouble. So having a low cholesterol doesn't protect you if you're insulin resistant from having a coronary. And again, if you had a high cholesterol and were insulin sensitive, there was little increased risk of coronary heart disease. So again, trying to give you a feeling for how much the risk of coronary heart disease is increased if you are also insulin resistant. Now, up to now we've been talking about populations at large without any comment about ethnicity. And the fact is that by and large, every ethnic group of non-European ancestry is more insulin resistant than are people of the European ethnicity. And this is a study from London. They're looking at individuals of European ancestry, South Asian ancestry, and in London or England, so-called Afro-Caribbean, which are mainly immigrants from Jamaica, etc. And over here, that's men and women. And women just had European and South Asian. And BMI, as you remember, again, is a mark of obesity. And as you can see, the three male groups had very similar BMIs. They were not they were not different in terms of adiposity. This is their so-called waist-hip ratio, the comparison of your waist over your hip. And supposedly having a high waist-hip ratio is supposed to make you more at risk. But again, they were not that different. The blood pressures weren't that different. But look at this. The proportion of the population that had type 2 diabetes in the UK, in the South Asian group, was 4 times that in the European group. The insulin levels were more than twice as high. They're insulin resistant. The cholesterol doesn't vary. Total cholesterol doesn't vary as a function of insulin resistant. The HDL cholesterol, remember, the lower that is, the worse off you are, and by far the lowest levels are in the South Asian men. Triglycerides, the highest levels are in the South Asian men. So everything you could think of that would increase risk of coronary heart disease and the prevalence of diabetes was increased. Now let's look at the women. Again, in this case, the South Asian women were somewhat heavier, with somewhat greater waist circumference, no difference in blood pressure, 8 times as much diabetes in the South Asian women. Insulin twice as high. Cholesterol no different. HDL cholesterol low, triglycerides high. All of the changes you see with insulin resistance. The next 2 slides are work we've done here comparing in the Bay Area South Asian men and women and men and women of European ancestry. And this slide is a measure of their insulin resistance. Remember, what we do is we infuse these insulin and the glucose, and at the end of the time, between 150 and 180 minutes, we make 4 measurements. And these are the insulin levels during that infusion. And as you can see, again, they're very similar. There's no difference. That's how the test works. But here are the steady-state plasma glucose levels. The higher those values, the more insulin resistant the people. And obviously, the South Asian men and women are almost twice as resistant as a group as the men and women of European ancestry. And they were matched for all other variables. So insulin resistance is more common in individuals of South Asian ancestry as a group. And lastly, because this is the important point, we measured the levels of blood sugar, glucose, and insulin throughout the day. 8 o'clock we gave breakfast, and at noon we gave lunch. As you can see, the glucoses aren't that different. Remember, again, these are non-diabetic individuals who are insulin resistant. So why do they not have a high glucose level? It's because they make a lot more insulin in the South Asian men and women, and the insulin is about twice as high, and that prevents the glucose from going up, but it still, unfortunately, leads to all the other changes we got through talking about, which greatly increase the risk of coronary heart disease. So the important point of all this is that insulin resistance, the ability of insulin to do its job, varies dramatically in the population at large. And 25 to 35% of the population at large is sufficiently insulin resistant to be a greatly increased risk for the abnormalities I talked about: type 2 diabetes, hypertension, coronary heart disease, and to a lesser extent, but still serious, polycystic ovary syndrome, fatty liver disease, and certain forms of cancer. Roughly half of the variability from person to person is due to how heavy they are or how fit they are. Roughly half is very likely genetic, and it's very clear that there are very profound ethnic differences. So clearly the take-home message is obvious that one, particularly in ethnic groups that are great risk, ought to understand what the risks are, how to make the measurements that will tell you if you're at risk or not. And the marvelous thing is, since only half of the differences are due to your genes, the other half are well within your ability to modify by changes in lifestyle. So thank you very much for your attention, and I'll be happy to answer questions. The question is, what is the ratio of triglyceride to HDL cholesterol, which is good and which is bad? I guess that's the question. Well, it's almost like you're reading my mind, because we are working on that right now, because one of the things we are trying to do is figure out how to identify people who are most at risk to be insulin resistant. And measuring insulin could be very helpful, but laboratories around the country don't make the same kinds of measurements. So a value in laboratory A and the same number in laboratory B may be something totally different. Right now, it looks to us that if you're a male or a postmenopausal female, that a ratio of about 3 or above is highly suggestive of being insulin resistant. The question is the insulin resistance increased prevalence in South Asian Indians due to genetics or food habits? It appears, we have not done every ethnic group at all, that although, let's say, ethnic group A may be more resistant than ethnic group B. In other words, the two groups on the average are different, but the factors that regulate it are not different. So in Caucasians from California, or South Asian Indians, or American Indians, or Mexican Americans, whatever, roughly half of the variation from person to person is almost certainly genes. Roughly half is almost certainly lifestyle, half adiposity, half fitness. The kind of food you eat will not make you more or less resistant. If you are insulin resistant, then changing the diet can be important. But the differences in fat or carbohydrate or protein, they don't make you insulin resistant or sensitive. Are we doing studies on weight loss and insulin resistance? In South Asian Indians, we are very interested in two things. We've been very interested, since more than half of the country is overweight by the criteria I talked about, and maybe 30% is obese. Yet we know that overweight doesn't equal insulin resistance. I mean, they aren't the same things. So the question is, since it's so hard to change lifestyle, how do you identify individuals who are insulin resistant, and then because only they will benefit from weight loss? So up to now, we've been doing this primarily on women of European ancestry, but we are hoping to start a whole new series of studies in which we would look for Asian Indian women who were insulin resistant, and then hoping that the benefit of weight loss will be as profound in them as it is in women of European ancestry. I see no reason why that won't be the case, but as of right now, this is one of our next research efforts, is to see how both study the prevalence of insulin resistance in South Asian Indian women, and more importantly, to select those who are overweight and resistant, and then hopefully be able to restore them to much less risk by weight loss. The question is, how much information do we have on various ethnic groups in terms of insulin resistance? I am not aware of any study, say, comparing Chinese to people of European ancestry. On the other hand, I spent many years going often to Taiwan and was very much involved in studies in Taipei in some of the hospitals there. And it seemed to me that the prevalence of insulin resistance in our studies in Taipei in general was much greater than it was in Caucasian, Europeans in Palo Alto. But I'm not aware of any direct measurements. We should do it someday. Maybe you can come join us and give me some advice on how to do that study, because I think it'd be really important. The question is the link between type 2 diabetes and obesity. There is no doubt that there are people who are normal weight who are insulin resistant. And that's because they have a particular, they picked the wrong parents. I mean, maybe 1 out of 6 people in the world at large who are insulin resistant are not overweight. So all overweight does is make your chances worse. Are there any other markers of insulin resistance that would be useful? And this is something we're trying very hard to do right now. And that's what I was talking about earlier on when I said that as of right now, if we can't use insulin, which is the best marker, but that doesn't help, that may help people in our lab, but doesn't help advice to the world at large. We have been playing with the triglyceride and HDL cholesterol because they are so tied up with insulin resistance. And right now, in males and women above 50, postmenopausal women roughly, a ratio of 3 has a specificity, as I remember, I'm roughly now about 65% or something like that, and sensitivity of about 65% and specificity about 70 or 80%. So it's a pretty darn good marker, and it certainly doesn't ever identify insulin-sensitive people. But that number applies to the upper third of the population. We're defining operationally those individuals as being insulin resistant. So it's not a bad marker. It's not great, and we're still, as I have to emphasize, we're still working on that. It's still something which we care a lot about, and we're trying to do it without using insulin.
Tonight, what I'd like to accomplish in the next 20 to 30 minutes is give you an outline on some background on coronary artery disease, discuss the epidemiology of coronary artery disease, risk factors for coronary artery disease, and subsequently the management and prevention. I would like to review some basic definitions. The definition of atherosclerosis refers to the buildup of plaque on the walls of arteries. And coronary artery disease refers to the buildup of plaque in the arteries which supply blood to the heart, thereby disrupting the flow of blood to the heart muscle. These are definitions which you'll come across during the course of this evening. Now, just so that we're all on the same page, heart disease comes in various forms. Not all heart disease is coronary artery disease. Heart disease can consist of heart valvular disease. It can consist of disease involving the thin sac covering the heart, referred to as pericarditis. It can refer to the inability of the heart to pump enough blood supply to meet the body's demands, which is referred to as heart failure. It can also refer to an irregular rhythm of the heart. But what we will focus on today is coronary artery disease. So just to give you some background information, there are about 12.6 million people in the United States that suffer from coronary artery disease. 6.4 million people suffer from stroke. In 1999 alone, about 500,000 people died from coronary artery disease. So the problem is coronary artery disease. Results from the World Health Organization's Monitoring Trends and Determinants in Cardiovascular Disease project, also referred to as the MONICA project, have confirmed that coronary artery disease is the major determinant of mortality in the Western population. 30% of the American population is non-white, and in California, over 40% of the population is non-white. Therefore, the growing ethnic populations require treating physicians to be aware of disease variability among ethnic groups to provide optimal care. So what do we know about coronary artery disease in South Asians? A lot of what we do know comes from reports of immigrants to countries such as the United Kingdom, Mauritius, Trinidad, and South Africa, and Fiji. In general, most immigrants tend to be healthier than the population they leave behind. Coronary artery disease mortality in the first generation of immigrants tends to be in between that of their country of origin and land of adoption. Within 1 or 2 generations, mortality patterns approach that of the adopted country. However, among South Asian immigrants, coronary artery disease mortality continues to diverge. The incidence and mortality of coronary artery disease is high among South Asian immigrants compared to their indigenous population. And this has been demonstrated in various populations in the United Kingdom, South Africa, Trinidad, and Mauritius, as I mentioned earlier. The risk of heart attack, also known as myocardial infarction, abbreviated there as MI, is about 2.5 to 5 times that of the indigenous population. The mortality from coronary artery disease is about 1.5 to 3 times in South Asians compared to their indigenous population. In the United Kingdom, South Asian men and women had excess coronary artery disease mortality of 36% and 46% respectively. A study performed in the United Kingdom looked at a prospective comparison of men admitted to the coronary care unit. What they found was that the rate of the first heart attack was 5 times higher in South Asians. The age of the first heart attack was lower in South Asians. The size of the heart attack, as determined by function of the heart chamber, as well as blood tests, showed that the size of the heart attack was greater in South Asians. And 3-vessel coronary artery disease, referring to the number of arteries that are involved, was also greater in South Asians. They also found that access in South Asian mortality was greatest in young persons. All these observations suggest that atherosclerosis is accelerated in South Asians, resulting in premature morbidity and mortality in this population. And the question is why? And the traditional risk factors alone have failed to explain the high incidence of coronary artery disease in the South Asian population. Insulin resistance syndrome, also referred to as Syndrome X, described by Dr. Reven, has been shown to be the major risk factor for increased coronary artery disease in South Asians, and consists of impaired glucose tolerance, elevated triglycerides, low HDL, high blood pressure, and obesity. A study performed in the United Kingdom surveyed 3,700 people. It looked at people who were involved in factory workforces as well as their general practitioners. Their age ranged between 40 and 64, and they looked at analysis of coronary artery disease risk factors in South Asian and non-South Asians. What they found was that South Asian group had higher prevalence of diabetes, higher serum insulin concentration, higher blood pressures, higher plasma triglycerides, and lower HDL. This is the data which Dr. Reven, I think, had summarized earlier as well, looking at higher prevalence of diabetes in the South Asian men, higher insulin levels in South Asian men, lower HDL, and higher triglycerides. Some of the other risk factors which I'd like to mention, which in addition to insulin resistance syndrome, which are being worked upon, are homocysteine and lipoprotein. These are novel risk factors and may also explain the increased risk of coronary artery disease in South Asians. Homocysteine is a sulfur-containing amino acid. Elevated levels of homocysteine are associated with increased risks of coronary artery disease. Homocysteine promotes vascular disease by affecting the lining of the vessels, referred to as the endothelium. And it also causes increased adhesiveness or stickiness of platelets. Elevated homocysteine levels can arise from 2 conditions: 1, genetic factors, and 2, nutritional deficiencies. Nutritional deficiencies in vitamin B6, B12, and folate all can lead to elevated homocysteine levels. A normal fasting plasma homocysteine is about 5 to 15 micromoles per liter. Plasma homocysteine levels over 16 micromoles per liter can lead to a 3 times increased risk of coronary artery disease. Another study conducted in the UK measured homocysteine levels in Indian, Asian men and European men, and they found that plasma homocysteine levels were elevated in Asians. These higher levels, they found, could be due to reduced intake of vitamin B12 and folate. And these elevated homocysteine levels could have contributed to twice as many coronary artery disease deaths in South Asians compared with Europeans. They verified similar results in various ethnic groups in Canada as well. The second novel risk factor which I would like to address is lipoprotein A. Homocysteine was elevated in about 30% of Asian Indians. Lipoprotein A is elevated in about 25 to 50% of Asian Indians. Lipoprotein A promotes coronary artery disease by increasing deposition of cholesterol in the arterial wall and interfering with fibrinolysis. High levels of lipoprotein A among South Asians are highly correlated with development and progression of coronary artery disease and incidence of premature heart attacks. Lipoprotein A levels over 20 milligrams per deciliter can increase your relative risk of heart disease by 2.7. Though we've talked about risk among South Asians as being greater compared to the non-South Asian population, there's also some heterogeneity among the risk factors between the various South Asian population groups. In general, Bangladeshis seem to have more risk factors than the Pakistanis or the Indians. Bangladeshis in general have higher triglycerides, higher fasting glucose, and low HDL, but they also have low blood pressure and are not as obese as Indians and Pakistanis. So we've talked a lot today about insulin resistance syndrome, also known as Syndrome X, but the main question is, what do we do about it? How do we manage this? So I'd like to point out this book, which I found very helpful. It's written by Dr. Reven. It's referred to as Syndrome X, and everything that I want to talk about is basically in this book to serve as a great reference. So basically, there's 6 steps to the management of Syndrome X. The first is the diagnosis. The next is the diet. Step 3 refers to weight loss, and then physical activity, then changing some of our lifestyle habits, and then medical intervention if needed. The diagnosis of Syndrome X involves some simple tests, but in addition to the testing, it involves educating both ourselves and our physicians to know which tests to perform and how to interpret them. So which tests do we perform? The tests to perform are a glucose tolerance test, a triglyceride test, an HDL cholesterol test, blood pressure, and weight. The first 3 are blood tests which can be performed fasting. Actually, they have to be performed fasting. The last 2, the blood pressure and the weight, are routine tests which you can get at your doctor's visit. So if the glucose tolerance test shows a fasting glucose level over 110 and a 2-hour glucose over 140, along with the triglycerides over 200, HDL less than 35, your blood pressure being high over 140 or 90, and you being obese with a BMI over 25 kilograms per meter squared, would predispose you to insulin resistance. The more of these characteristics that you have, the more likely that you will have coronary artery disease due to Syndrome X. There's also some feeling that the BMI of 25 kilograms per meter squared refers to for the general population, but since the South Asian population is at increased risk of insulin resistance, it is actually recommended that their BMI be around 23 kilograms per meter squared. So just to reiterate, the more of these characteristics you have, the more likely that you're going to have coronary artery disease due to Syndrome X. Now, the Syndrome X diet. The Syndrome X diet, initially, when you first look at it, seems unusual in that we are actually encouraging you to eat more fat. It's a diet which is high in polyunsaturated and monounsaturated fat, but moderate in carbohydrates. So the number is 15% protein, 40% fat, predominantly polyunsaturated and monounsaturated fat, and 45% carbohydrates. So most people will ask, wow, I can eat more fat. Well, it's true, you can eat more fat, but the type of fat you have to eat has to be unsaturated fat. Why is it that you can eat more fat? Well, insulin levels do not increase when we eat fat. If we substitute fat for carbohydrates, our insulin levels will fall. Once again, you cannot eat just any fat, but you need to eat unsaturated fats. So what are unsaturated fats? Unsaturated fats basically have less hydrogen groups, but in terms of practical terms, they consist of foods like corn oil, sunflower oil, olive oil, canola oil, peanut oil. In terms of foods, they include foods such as nuts, almonds, cashews, peanuts. They include avocados and olives. The bad fat is the saturated fat, which we don't want you to increase, and that includes meats, butters, cheese, ice cream, and animal products. So just to give you an example, you could cut back on a lot of, I tailored this towards a little bit on the South Asian diet, but you'd cut back a lot on the rice, a lot on the potatoes, the breads, the chapatis, the bagels, and the chips, and eat a lot more beans, vegetables, lentils, fruit, yogurt, and nuts. So nobody has to say that you stop eating rice and chapatis and potatoes, but just eat less. So instead of eating a cup of rice, eat half a cup of rice and eat more lentils and beans. Instead of eating more potatoes, eat more vegetables. Instead of snacking with chips at your desk, you can snack with nuts and yogurts. So it's really just a change in your diet. And the results of this diet will be a decrease in insulin levels, which will lead to lower triglycerides. It will raise your HDL, which is the good cholesterol, and lower your LDL, which is the bad cholesterol. The next step is weight loss. And the reason that weight loss is good is because if you're obese, the insulin is not as effective. So your body has to produce more insulin to keep glucose under control, which leads to increased insulin levels, and you're more likely to develop the manifestations of Syndrome X. So lower insulin levels reduce harmful effects of Syndrome X. And even if you don't have Syndrome X, losing weight can be beneficial to reduce your risk factors for coronary artery disease. So how do we lose weight? Well, we can reduce our calorie intake. These are just some general guidelines. You can consume about 30 to 35 calories per kilogram of your ideal body weight. For a small woman who weighs about 50 kilograms, that would be about 1,500 calories to consume during the day. And for a large man, that would be about 2,100 calories. So just cutting back on our calories and changing our diet from carbohydrates to unsaturated fats will help us to improve insulin-resistant syndrome. In addition, physical activity will help us to lose weight. The more we exercise, the more insulin sensitive we will be. As a result, insulin levels will decrease, triglyceride levels will decrease, and HDL levels will increase. And just other lifestyle habits, smoking. Smoking also causes us to be insulin resistant. As a result, there's increased insulin levels, and we're more likely to develop the manifestations of Syndrome X. Consequently, stop smoking, insulin sensitivity increases, insulin levels decrease, triglycerides decrease, and HDL increases. So diet, exercise, and lifestyle changes are really the mainstay therapy for Syndrome X. But there are medical interventions, and the medicines that are used fall into these three groups: insulin sensitizers, drugs to lower triglycerides, and antihypertensive agents. Syndrome X is triggered by insulin resistance, which causes the pancreas to secrete more insulin. Can Syndrome X be defeated by using drugs which makes the body's cells more sensitive to insulin? The answer to that is unclear. The body's cells can become more sensitive to insulin by a certain group of drugs called glitazones. The side effects of these drugs are liver toxicity, and there's been no study to show that use of these insulin sensitizers reduce the risk of coronary artery disease. What about elevated triglycerides? There are drugs to reduce triglycerides levels, and these include nicotinic acid and fibric acid. Nicotinic acid slows the release of fatty acids from fat cells, thereby decreasing your triglyceride levels and LDL. But the side effect includes flushing. For about 15 to 20 minutes after you take the drug, people complain of the large flushing feeling all over their face and body. Fibric acid, two types of drugs are gemfibrozole and fenofibrate. They decrease the liver's production of triglyceride-rich particles, but their side effect is also liver toxicity. And then high blood pressure. There are 5 different classes of drugs which one can use to treat high blood pressure. They fall into the range of diuretics, beta blockers, alpha blockers, calcium channel blockers, and ACE inhibitors. All these drugs have their own side effects. The key things to remember is that the goal blood pressure should be less than 140/90. Very often you need at least 2 drugs to maintain this blood pressure. Diuretics and beta blockers can worsen your glucose tolerance and your lipid profile. Low-dose diuretics do not have an adverse effect in terms of the insulin resistance syndrome, but higher dose diuretics can have an adverse effect on the insulin resistance syndrome. And beta blockers after heart attacks have beneficial effects. This is just a general guideline of the various medications which can be used to treat high blood pressure. But as mentioned earlier, diet and lifestyle changes and exercise remain the mainstay therapy. We had mentioned earlier some novel risk factors of homocysteine and lipoprotein, and drugs to reduce elevated homocysteine levels include folic acid, which is a vitamin. Its side effects are fairly benign, whereas for elevated lipoprotein A, the drug includes niacin, and as we mentioned earlier, it causes flushing about 15 to 20 minutes after you take the medicine. In general, I feel the goal here, the take-home message, is to really educate ourselves, the physicians, about primary prevention of coronary artery disease. And primary prevention of coronary artery disease can be performed by identifying high-risk patients early on, based on our ethnic backgrounds, our family history, and screening for insulin resistance syndrome by the various tests mentioned earlier. And once these patients have been identified, then of course an aggressive intervention, which predominantly involves diet and lifestyle changes to alter our blood pressure, decrease our insulin resistance, and alter the lipid profiles. Where do we go from here? I think the future direction really takes us to more epidemiological and therapeutic outcome studies looking at various ethnic groups. In addition, we should have some studies focusing on the management and treatment of syndrome X with lifestyle changes and pharmacological changes. I'd like to acknowledge Dr. Reven and a colleague of mine, Dr. Schaub, both of whom have been very helpful in sharing their knowledge and research experience on this topic with me. Thank you. So the question is, can I distinguish between low glycemic and high glycemic carbohydrates? So high glycemic carbohydrates, I think things like rice and potatoes, which I think you should cut back on. And the good type of carbohydrates would be, even lentils have carbohydrates, so lentils and even fruits would be your sort of low glycemic carbohydrates.
When you eat pure different starches, they all should go to glucose. And the plasma glucose and insulin levels theoretically should be the same. It turns out that the physical nature of different kinds of starches makes some of those more easily absorbed. Therefore, they can give a more quick increase in the blood and higher insulin levels. And you can see that if you, say, compare bread and rice or something. On the other hand, when you mix those things up with meals, where you're eating protein and fat and carbohydrate sources, the impact of difference in the kind of carbohydrate is relatively modest. And if you look at low-fat, high carbohydrate, low glycemic index foods, that is not as effective as simply decreasing the amount of carbohydrate. So within that decrease in terms of total carbohydrate, if you want to worry about the kind of carbohydrate, that's fine. But it seems to me the 3 most basic principles in terms of healthy diet is decrease saturated fat. No, the biggest thing is decrease, if you're overweight, decrease total calories. Weight is by far the most profound effect. The second thing would be to decrease saturated fat intake to get the lowest LDL cholesterol you can. And the third thing is don't increase carbohydrates. Then you go beyond that, you can begin worrying about the kind of this or the kind of that, but they're just not as powerful. So a high carbohydrate, low glycemic index diet does not help as much as simply reducing carbohydrate.
So the question is a fasting glucose tolerance test sufficient, or do we also need a 2-hour test? And I think we do need a 2-hour test, and just the fasting glucose test is not sufficient. In addition to that, we should also do the triglycerides and the HDL and the fractionated lipid panel, and I think Dr. Reven can add to this.
Fasting glucose that is considered to be abnormal, which is above 110 and less than 126, and supposedly is something that's predicting insulin resistance, is very insensitive. There's a classical phrase, the sensitivity of this test, and for the fasting glucose, it's about 10%. If you have a fasting glucose above 110, that is highly suggestive of insulin resistance. But if it's less than 110, 1/4 of the insulin-resistant people would be missed. The 2-hour value is not perfect, but it increases almost from 10 to 40% the sensitivity. So again, it's a question of how aggressive one wants to be. And I think what neither one of us mentioned is that having, say, a family history of hypertension or heart disease or diabetes would again should make the doctor more aggressive in looking for these abnormalities. So the fasting glucose is, if you have it, terrific. If you don't have it, it doesn't tell you a great deal. The 2-hour value is not perfect either, but it's better than the fasting by 3 to 4-fold.
So the question is, how can somebody find out about a blockage that is 70 to 80% and prevent a heart attack? So just to give you some background, heart attacks are not caused by blockages that are 70 to 80%. Very often heart attacks, and most heart attacks in fact, are caused by blockages which are only 30 or 40%. Because a small plaque will break off, go downstream, and cause the heart attack. In terms of blockages that are 70 to 80%, they can be detected usually by a stress test. Stress tests can detect blockages that are physiologically significant, which is usually blockages over 60 to 70%. But that does not reduce your risk of having a heart attack because, as mentioned earlier, most heart attacks happen with small blockages, minimal blockages, which will not show up on a stress test. And even if they show up on an angiogram, we will not do anything with those blockages that are under 60% on an angiogram. What we can do is make those plaques more stable. And to make them more stable, we recommend taking care of your cholesterol, do not smoke, take care of your blood pressure. So at the end of the day, to prevent a heart attack, you still have to have diet and lifestyle changes to prevent a heart attack, and not really the stress test or the angiogram. The question is, with exercise, which fraction of the lipid panel gets affected the most?
Well, exercise will enhance insulin sensitivity. I mean, aerobic exercise of significant amount, let's say half an hour, 3-4 times a week, will clearly make you more insulin sensitive. HDL always moves less than triglycerides. So triglycerides, insulin will fall, triglycerides will fall, HDL will go up, but proportionally the first two change more dramatically. HDL is much more, moves less than insulin and triglycerides do, probably because of the day-by-day fluctuation in caloric intake. The question is, there is a thing called hemoglobin A1C, or glycosylated hemoglobin, and that is just measuring a proportion of your hemoglobin which has glucose attached to it chemically. It's very useful for people who really have high glucose levels and as a way to monitor the treatment of diabetes. It's not particularly useful at all to discern the kind of small differences you see here, because again, the entire nature of this problem is the glucose doesn't change that much. It's the insulin which is the change. So for example, if you take people who have what's called impaired glucose tolerance, which is you give them a glucose challenge by mouth, and you measure the glucose subsequently a little higher than the average person, that is in response to a pure glucose challenge. When you give them food throughout the day, you don't see that much difference in the plasma glucose levels. The insulin levels would change dramatically, so therefore the hemoglobin A1C doesn't become terribly useful under those conditions.
A lot of the data that we know about immigrants other than South Asians comes from the Japanese immigrants. And when the Japanese immigrants come, in the first generation, they're in between the people they left behind in here. And then eventually their risk factors and the risk for heart disease approaches that of the land they adopted, whereas for South Asians, we don't, our risk for heart disease continues to diverge in the sense of, we are still at high risk for coronary artery disease. We are not at a lower risk like the European population. We're at high risk, and part of it is, all of it is insulin resistance syndrome, and half of that, as Dr. Yoon mentioned, was genetic, and the other half was our lifestyle and our fitness. So half of it we can take care of by changing lifestyle and our fitness, but the other half of it is genetic, and so the genetic predisposition to the insulin resistance syndrome. And so that's why we do not approach the same numbers as the European population, whereas the Japanese immigrants who did migrate, their risk for coronary artery disease eventually down the line approaches that of the European or the American population where they migrated to.
Thank you.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.